A very good day, my dear postgraduate students. Recently, after having started this bone marrow aspirations, one of the students had asked me the interpretation of it. So I thought it was apt to have one class started at least. And the topic for the day is megaloblastic anemia. Before I go any further, I would like you people to repeatedly appreciate this particular flow diagram. There is a hematopoietic stem cell, and then it becomes progressively committed. There is a progenitor that can lead to the myeloid and the erythroid series. Also, another one can be leading on to the megakaryocyte. So this will be important for us. In this particular class, I will be concentrating on the erythroid series alone since it is a megaloblastic anemia. Please do remember the basics. Basics are basics. Always you should be strong. There is a proerythroblast, basophilic erythroblast, polychromatic, orthochromatic, and finally the erythrocyte. In this one, I find that there is an orangish or a pinkish orange cytoplasm almost similar to the erythrocyte. The other things apart, we shall be seeing them. Now this is a text I had pertinently taken from my book, one page. A handbook of pathology for undergraduates, but then okay. For the class, it shall be enough for us. Cellularity. The bone marrow, it can be either hypercellular or it can be normal cellular. And you find that there is an erythroid hyperplasia. And you people will have to discuss the erythropoiesis, whether it is active, what is the pattern of maturation, megaloblastic pattern of maturation. What then do I mean by the megaloblastic pattern? You find that the nuclear maturation lags behind the cytoplasmic maturation. The nucleus is large. It has got an opened out chromatin. And there can be the other counterparts also lagging behind, such as the megaloblast, etc. You may be seeing the giant staph forms. So, giant metamyelocytes or the staph forms are seen over here. People say that this has got nothing to do with the disc hematopoiesis, but then it is again a hallmark of megaloblastic anemia. Lymphocytes and plasma cells are unremarkable because it is a different lineage that is not affected by either B12 or the folic acid. Myeloid erythroid ratio, you find it is reduced or even reversed. Normally it is 2.5 to 15 is to 1. 15 times myeloid and 1 of the erythroid. It can be even reversed. Iron stores are increased because megaloblastic anemia is a milder form of hemolytic anemia. Always we people should be familiar with the other changes in any disorder whatsoever. For example, all of us know that there can be a chronic gastritis, there can be an intestinal metaplasia, subacute combined degeneration of the spinal cord, classical of the pernicious anemia, mild hemolysis with mild increase in serum bilirubin. And this is the blood picture. All of us know about it. I am not going to delve into it. But then there can be the hypersegmented neutrophil. So more than 5% of the cells will be having more than 5 segments. Macrovolocytes, all jolly bodies, etc. You people can read up. This again, going back to fundamentals. You find that there is the hematocytoblast or a committed stem cell from which you can have the proerythroblast, myeloblast, lymphomonoblast, and then the megakaryoblast and sites. So this is one thing that we should always be having in mind, because sometimes in a stem cell, when there is a disorder, it can affect all the lineages. This particularly happens in the case of chronic myeloid leukemia. You find that there is not much of anemia, increase in platelets, increase in the leukocyte count, etc. And so also in a megaloblastic anemia where all the lineages are being affected. I would like your comments on this. I'm just waiting for your comments. Kindly compare these. So always you find that the blast will be slightly larger. This is a normoblast. And having a purplish tinge, it is a polychromatic normoblast, larger than the normal erythrocytes that we do see. Whereas in this case, it is very much larger, almost akin to a blast cell that we can see in a leukemia. And more important will be certain points that we will have to appreciate. The nucleus is slightly towards the periphery or eccentric we can say, and it has got an opened out chromatin, a sieve like. So this is something that we use for filtering the flour in the kitchen. And this is again a normal erythropoiesis or a normal bone marrow. I find that there are probably these are some cells, maybe myeloid or megaloblastoid. But then most of these cells, they are again I'm seeing a polychromatic normoblast, and then this is probably somewhere earlier. Always identify a cell by the company it keeps. We will be having a doubt when we do a differential count whether it is a lymphocyte or an erythroblast. In this case, I find that there are too many such cells. Here I am not sure whether it is a lymphocyte or a normoblast. So in such a case, what I do is I compare it with the other cells, and it is unlikely that there will be a lymphocyte right in the middle of a cluster of these erythrocytes. So identify a cell by the company it keeps. Again, you are seeing a giant stab form over here. It can be larger even than the other cells, larger than the myelocyte. So it is called a giant stab. In spite of such active hematopoiesis and erythropoiesis, you find that the patient will be having an anemia because of dyserythropoiesis. It is not able to survive its entire term, and there will be a milder degree of hemolysis. Again from my book, one page. So the bone marrow picture in a case of megaloblastic anemia. You are able to see a giant stab form. This is a megaloblast. Probably it is a basophilic or a promegaloblast that is over here. There is a larger nucleus, slightly eccentric basophilic tinge, so also over here. And even as the cell becomes more and more mature, you find that the nucleus lags behind. This is a polychromatic cell, but then there is a large nucleus and it is becoming orthochromatic, almost like the RBC, but the nucleus is still in position. It is of course contracted, but it is not expanded. Here I am finding some kind of a blebbing in the nuclear membrane. Here again a dual nuclei. These all can be examples of dyserythropoiesis. There is of course, this is probably picked up from the peripheral blood. I am able to see some kind of hyperpigmentation in the neutrophil. So look at the cells. Always a differential count is the key to your success. Dyserythropoiesis, ineffective erythropoiesis, megaloblast with opened out chromatin, nuclear lag in maturation, and look at this picture again. I would like you people to kindly appreciate it is from my text, one page. This is a bone marrow picture in a case of megaloblastic anemia, wherein I am seeing certain changes. This large cell with a bluish cytoplasm is probably a promegaloblast, equivalent to a pronormoblast. Then you get the basophilic normoblast or megaloblast and so on. But in this case, I am finding a large nucleus, slightly eccentric, one or two nucleoli, and there is a basophilic cytoplasm. Same is being appreciated over here. But even as the series matures, this is a polychromatic, this is an orthochromatic cell, I find that the nucleus is still lagging behind, though there is a condensation of the chromatin. Again, there is a cell with dual nuclei that have become incompletely separated. Something is wrong with the development. We can call it as dyserythropoiesis. There is a cytoplasmic bleb, nuclear bleb that I am seeing. And a giant stab form is also there for us. It may be even larger than the myelocyte or even a promyelocyte. So what should we see? The dyserythropoiesis, ineffective erythropoiesis, megaloblast with the opened out chromatin, nuclear lag in maturation, giant stab forms, sometimes this megakaryopoiesis, abnormal mitosis, and Hall Jolly bodies. Look at this Hall Jolly bodies. Again, describe it. This is something just to show the hypersegmented neutrophil and the macroholocytes, but this is what I'm interested in. So I find that there is a large cell, and what I wanted to tell you people, identify a cell by the company it keeps. You are finding so many of these cells with a large opened out chromatin. We'll always be having a doubt whether it is a myelocyte or whether it is a promyelocyte or a myeloblast because it doesn't have any granule. But then opened out chromatin, sieve-like pattern, eccentric nucleus, nucleus lagging behind the cytoplasmic maturation. Look at this one. Had I thought this to be a blast, then this is unlikely. There is a polychromatic cytoplasm that I'm seeing, but the nucleus is similar. Therefore, what did I tell you? Identify a cell by the company it keeps. So these are all the megaloblasts that you people are seeing. Always it is a dictum. Look for the clinical history, a complete hemogram, concurrent peripheral smear, and the treatment history. There are only two rules for being successful. One, to find out exactly what you want to do, and two, to do it. Mario Cuomo. A very strange experience. There is a case of a doctor who came with a severe anemia, and then he was discontinued with most of the medication that he had been given earlier. And finally, when a bone marrow aspiration was done on him, we found it to be highly cellular and it was showing atypical mitosis. We were a little worried whether it is a leukemia or something. But then my professor, Dr. Ramesh Rao, said, it is unlikely that a myeloblast and further down will be multiplying unless it happens to be a stem cell leukemia. Therefore, let us go into the history, and it was found that the doctor was in fact a research scholar, a PhD with a DR in front of his name. And so he had been exposed to some kind of radiation or chemicals, we do not know, that has caused a bone marrow suppression. And once he was admitted in our hospital, the bone marrow recovered, and hence we saw all the weird items like these. Look at this one. This is taken from another one, just like an analogy. Whenever we say mitosis, it is not going to be prophase, metaphase, anaphase, and telophase. Sometimes it can be asymmetrical. It can be tripolar over here. Sometimes there can be karyokinesis. Multiple fragments can be there. Multipolar mitosis. All this can be the basis for an anaplastic neoplasm, but also in dyserythropoiesis and also in a case of a marrow that is recovering from suppression. Now, I've frequently been harping upon the word of hemolytic anemia. What are the differences between megaloblastic anemia and hemolytic anemia? I had given it in a tabular column. I would like you people to kindly go through. Most of the things you people already, this is a very important and educative table. And the differences between a megaloblastic and non-megaloblastic macrocytic anemia. B12 deficiency or folic acid deficiency or pernicious anemia. Whereas alcoholic liver disease, then it can be because of the polychromatic cells or the reticulocytes, hemolytic anemia, hypothyroidism, aplastic anemia, and other causes of macrocytosis such as liver disorders. Sometimes even in a case of aplasia, you will be having the macrocytes. So these are things that you'll have to have. Look for the macroholocyte as well as the giant staph. Can you explain all this? A beautiful referential diagram taken from this one, all credits to them. I had shown you people the opened out chromatin and identification of the cell by the company it keeps. So there is an increased NC ratio, immature, open sieve-like chromatin, lag in the nuclear maturation, and eccentric nucleus. So this is a normal. As I told you, identify the cell by the company it keeps. Various series of the normoblast. The same over here, and then I find that there is a hypersegmentation and opened out chromatin. There is a dyserythropoiesis, cytoplasmic and a nuclear blibbing that is seen. Again, a dyserythropoiesis. This is again a friend of ours, the megaloblast, but then, I'm sorry, the megakaryocyte. I find that there is multiple segmentation. It can be hyperlobated or it can be hypolobated. And you find it is suppressed in most of the cases, but it can be normal. A mild degree of thrombocytopenia will always be seen in the peripheral blood. And all of these are because of the defect in the DNA synthesis, which is common to erythroblast, myeloblast, as well as the megakaryoblast. So identify. So this is an immature cell. Probably it is a basophilic or a pro-erythroblast that we are seeing. You should be able to identify all these cells. And here again, I'm able to see a giant stab form. Look at the opened out chromatin. I'm sure you people will be able to identify. References, hematological outlines for this diagram, the normal RBC over here, and then this is a polychromatic cell that is there. So there's a megaloblastoid chain with a large nucleus, opened out chromatin lagging behind the cytoplasmic maturation. We had already seen all this. Repetition is the mother of learning, the father of action, which makes it the architect of accomplishment. Thank you.